So I'd like to start off with a vignette and introduce to you Mario, who's an 8-year-old boy in grade 3 at a local school. He lives with his mother and 5-year-old brother, who's in junior kindergarten. The family left Colombia 1 year ago because of political situations. Mario's mother works at part-time in a donut shop, and she's trying to attend an adult learning class to learn English. Mario's father is still in Colombia, and the family hasn't heard from him for the past 9 months. And Mario is actually referred to you as a community pediatrician because he's having difficulty with schoolwork. He's having problems learning to read and paying attention in class and needs a lot of supervision to get his work done. Not only that, he's actually very disruptive and fights with not only his teacher but students also. So this brings up many different potential issues. Things that could potentially go through your mind would be, is this a straightforward case of ADHD? Is there a learning disorder issue associated with his school performance? Or has his previous school performance affected what his performance is currently? So what exactly did he previously do? Did he actually even attend school in Colombia? Was he in a private school? Or was he only speaking Spanish or another language? And what was that school setup like? How has trauma affected him? So they left quite quickly, and the father is still in Colombia, and they actually haven't heard from him for some period of time. So that's for sure weighing on his mind. Not only that, was he affected by violence or something terrible to him specifically, such that he has PTSD, or is he depressed? So there's many different questions that we will not be able to answer wholly, but we'll give you a primer about how to get those answers and how to approach these kinds of patients. The second case I'd like to introduce you to, and we'll get back a little later, is little Yemen, who's a 16-year-old born in a UN refugee camp in Thailand. Her family was originally from Myanmar and arrived in Red Deer when she was 7 months of age. Her mother had no routine prenatal care in the UN refugee camps. She was there for approximately 2 years. And over the past 2 weeks, Yemen hasn't been doing very well. She's had a cough and a low-grade fever, and she's not gaining any weight over the past couple months. She has a fever to 38.5 degrees Celsius orally. She has a respiratory rate of 60 breaths per minute, and on auscultation, there's some fine crackles in her lungs. You do further examination, you find an enlarged liver and spleen and enlarged cervical lymph nodes. So again, is this a routine viral pneumonia that you're seeing in Red Deer that's circulating currently? Or is this something more ominous? Could it be related to something that was associated with either the refugee camp or from their initial country of origin? You've potentially heard about high levels of sexual violence in refugee camps, and then you worry, could the mother have HIV and had perinatal transmission of HIV because there was no testing and no prenatal care. And then you ask yourself, but shouldn't the mother have been tested as part of coming to Canada? And shouldn't the child have been tested as part of coming to Canada? And perhaps you'd actually have to find those kind of resources. So lots of questions again that hopefully we'll be able to peel back some of these layers and give you some resources to go forward. So the first thing we need to do is actually define what we're talking about, and what we're talking about are permanent residents and temporary residents. And this is how Citizen Immigration Canada defines newcomers to Canada. And under permanent residents, we have the family class, we have economic migrants, we have government-assisted refugees, or also called GARs, and privately sponsored refugees, and there's a very small other class in there. Under temporary residence, we have refugee claimants and foreign students, temporary foreign workers, and humanitarian cases. So this is the breakdown over time associated with the various categories specific to permanent residents. And if you see that of the 250,000 newcomers to Canada every year, on average, most of them are actually in the economic class. And more and more, that's actually being increasing in numbers at the expense of other classes. Specifically, the family class and refugees have been overall stable, and other, which is a small proportion, has also been stable. Not only that, 20% of all permanent residents or newcomers to Canada are children, and that reflects what our demographics are of born in Canada demographics. So where do these people settle? Where do these newcomers to Canada settle? And so not only do they settle in the larger metropolitan areas, and certainly within the provinces of Ontario, Quebec, British Columbia, but certainly Alberta, Manitoba, and we're seeing more and more Saskatchewan, New Brunswick, Newfoundland, and also the territories. But they're also settling not only in large metropolitan areas, which we typically think of as where refugees and immigrants settle, but they're also settling in places like this. So anybody can tell me where this is? Perhaps you even actually practice in this setting here. It's north of here, northwest, many hundred kilometers away. Beautiful setting. I've been there personally. This is actually Whitehorse, and in 2011, which we have the latest data from CIC, Citizen Immigration Canada, there were 218 permanent residents settled to Whitehorse of a population of approximately 25,000. So not only are you seeing these patients, newcomers to Canada, in large metropolitan areas, but you're also seeing them in areas that maybe don't have all the resources that you would require or benefit from. And so that's why one of the big impetus for this online web resource is to provide everybody the appropriate resources to best take care of these patients. Where are people coming from? Well, they're coming from all around the world. Right now, there's a lot of Southeast Asia focus, Philippines, China, India, and then the United States, United Kingdom, and a few other various areas of the world. That's for the permanent residents, but in terms of refugee claimants, which is a smaller subset of people who come to Canada, a significant proportion are coming from Hungary, China, Colombia, Pakistan, Namibia, Nigeria, and Mexico. And the list keeps on going down, but these are the major places where people are coming from. And what do they speak? And we'll speak about why it's important to know this, but the highest language of the language of origin is Tagalog, which is the Philippines language, Arabic, Mandarin, English-speaking countries, Spanish, Punjabi, French, and Creole. But what is their language abilities? People coming to Canada have, approximately 58% of them, or almost a little over half of them, have the ability to speak English. A small proportion have the ability to speak French, and then a small proportion also have the ability to speak English and French. But what's most important is that a quarter of the people coming to Canada have no ability to speak either of our official languages. And so we need to ensure that we can communicate best with our new population. So going on to the next case. This is Fatima, who's 4 years of age, who comes to your office for increasing urinary accidents and incontinence and vague abdominal discomfort. As part of your workup, you request a urinalysis and a culture and perhaps an abdominal ultrasound. Fatima's parents asked you actually if you could see her 12-year-old sister, Rashimi, for fatigue and heavy periods. You receive Fatima's reports, but Rashimi's investigations kind of are missing, and you question the parents about why you don't get any testing results associated with the older sister. But what you learn is actually that the parents are in Canada on a work visa, and they have provincial permits to work, and they've applied for immigration status, but actually have not received any documents as of yet. Fatima was actually born in Canada, and so because she was born in Canada, she has provincial health care coverage. However, Rashmi was actually born in Sri Lanka and immigrated and came to Canada with her parents approximately 6 years of age. So therefore, she's actually ineligible for provincial health care insurance, and her family can't afford these investigations for her. So that really outlines and drives home this issue about barriers to care in this newcomer population. So not only barriers to care are they systematic, but there's also this mistrust of government and also services that are official. There's also a language, literacy, and cultural barrier. So in terms of systematic, you can understand that associated with the IFH coverage and other things of that nature, there's entitlement issues. So some people are entitled to coverage of various different levels, and others are not. Not only that, there's actually a lack of provider skills. So some people don't understand the issues associated with newcomers to Canada. And then they're on the patient side, they just don't understand at times what the healthcare system in Canada really means. Have they ever seen a physician before for a full history and physical? Do they really understand what anticipatory guidance or health promotion is? Perhaps they've only gone to the hospital or seen a physician in very dire circumstances. And then limited pre-arrival health care, and then certainly, as was illustrated in this case, precarious finances. They don't have the money to pay when there's no health insurance associated with it. In terms of mistrust of government, there's many people come from places, especially refugee claimants, where they've been abused or tortured, or the government is not their friend, right? So not only that, many of them have been detained, not only in their country of origin or in their migration pathway, but a few of them have potentially been detained in Canada. And many of them have actually been separated from their family. In terms of language, literacy, and cultural barriers, there's certainly stigmatization associated and with some diagnoses. There's certainly a lot associated with mental illness. Family dynamics, which Tony will be speaking to a little further down the road. And then just a different understanding of what health and what disease means. So all these big issues are huge barriers to care associated with this newcomer population. How does culture influence health? Well, culture is this pattern of ideas and customs and behaviors that's shared by a particular society or people. And you can see that culture is not a static thing, it's an evolving thing that's learned and passed on from generation to generation. And it's a shared resource, it's a shared kind of concept. I'll give you two more examples of how culture can actually be different when you think it potentially would be the same. So Marian, a 10-year-old girl from Sudan, lived for 3 years as a less than cared for child with an aunt who had 4 other children. Her mother, who was a Sudanese journalist, was persecuted and jailed after writing politically sensitive articles in the national newspaper. One night, her mother suddenly arrived to take the child away under the cover of darkness. They walked all night and slipped across the border. Once across, they lived in a refugee camp for 2 years, facing various difficulties because they didn't have a male family member to protect them. Eventually, with the assistance of the United Nations Commission for Refugees and the Canadian government, they were sponsored as government-assisted refugees and made their way to Canada. The mother is experiencing post-traumatic stress disorder, and although she's being treated, she's having very difficult time functioning on a day-to-day basis. However, her daughter actually adapts quite quickly and becomes the mother's interpreter and caregiver, and she appears well adapted, doing well in school, motivated to help her mother, and learning English. Contrast that situation with a 10-year-old girl, also from Sudan, a daughter of a school teacher in a wealthy area in Khartoum, who left the country with her mother under the protection of a diplomat during a stable period. This diplomat arranged for visas to Germany, and a car with diplomatic license plates and a skillful driver drove them to the safest airport. They got on a small plane and connected with a prearranged flight in Germany. And then the mother and daughter lived there for 2 years in Frankfurt, and the child attended school there while the mother worked as a tutor. They rented a room from a friend and were doing relatively well. Ultimately, they decided to migrate to Canada and to join an extended family who sponsored them. And once arriving in Canada, the mother remarried after arriving. So you can see that although both these 10-year-old girls are from Sudan, a specific area, you can see that they have really different culture, and not only that, they have very different trajectory associated with their migration. And it really affects their outcomes and their barriers. And so just as a cautionary note to ensure that you don't paint big brush strokes associated with people from certain areas, because they can have very different trajectories.
So this is one of the lead pages of our website, just as a reminder to go and visit the website, please. We'd like you to take a look. I'm going to speak a little bit about the medical assessment of immigrant and refugee children. This is, as previously mentioned, taken right from the website itself, and I'll just try to walk through it a little bit to give you an idea of what you can find. To some degree, getting to know a new immigrant or refugee family is not that different than any other new family coming to your practice. But at the same time, there are subtle differences in terms of your focus, in terms of your need to figure out the types of interactions and the subtleties of the interactions, as well as the interpretation of both symptoms and signs, and not to mention the interpretation that goes along with the language differentials that are often there. Being sensitive and aware of cultural and language differences goes without saying, and also keeping in mind that some of these children will have not ever had really a reliable, complete, thorough examination, and so your job as a first-time intervention primary care providers is looking for everything from congenital anomalies to chronic diseases that have not been adequately treated or identified. And as well, there are differences in terms of the actual presentations themselves, of the different problems, both physical and mental, and the way that they are either brought forward, accepted culturally, or perceived. Now, the initial assessment really is no different in terms of flow, other than to say that you need to be certainly quite flexible. Sometimes that first visit to you will be a very acute issue. Someone coming with a specific problem, a fever, a chronic diarrhea, whatever it may be, in which case you obviously will be dealing with the problem at hand. Sometimes it may even lead to a hospitalization. Not necessarily the best situation to build trust per se, but ideally, if you have an opportunity, subsequent evaluation or a separate evaluation to deal with more general issues and to try to get a better understanding of who the family is and the child is and where they've come from. Also, in terms of timing, ideally trying to have a refugee or immigrant family be seen within short order of arriving certainly can make a difference in terms of both establishing rapport, but as well addressing issues that may be either ongoing or certainly soon to be visible. And again, in a perfect world, separating children in the sense that the complexity there is already time-consuming now, but keeping in mind that many families may not have the resources or the ability to have one children come at a time, and so sometimes you need to be adaptable. In terms of preparing for the visit, well, documentation. If you can get pre-immigration documentation and screening and immunizations and records and growth charts, all the more power to you. Keep in mind that many of these will then need to be translated, and the accuracy is not necessarily great. So everything needs to be interpreted to some degree with a grain of salt. But certainly if you can access them, photocopy them, return them to the families, that's very useful for your own day-to-day practice. And as well, being prepared. So if you know they're coming to your office, figuring out who the right person in the room to help you get the most out of each visit will be useful. Whether it's an interpreter, a settlement worker, another family member who can act as a go-between, that's very useful. Now, most of medicine comes down to effective communication, and dealing with families who are new to Canada is no different. Clinical demeanor is obviously hugely important. Having a smile on your face, knowing a welcome in Tagalog if that's the population that you deal with, allowing for adequate time to develop a sense of trust and not feeling rushed. Not easy in a busy practice, and especially in settings where resources are scarce. Also being respectful of culture. So, you know, sometimes a greeting is not a handshake, and eye contact is not exactly warranted. And knowing the population and the group of children and families that you're dealing with and what their customs are is helpful. The family dynamics Chuck alluded to. Family dynamics, when I talk about that, I'm speaking to the who in the room is sort of in charge. You know, in North American culture, it's quite common for us to directly ask questions of a younger child or an adolescent. That may not be the way to go in an older in a child who's coming from a different culture. Sometimes the direct person to deal with is an authority figure, a parent, a grandparent. Even though they may not have all the information, the way that you direct your questions may have to flow in that route first. As well, in terms of divulging of information about family function, family structure, marriage, common law, polygamy in some cultures may not be forthcoming in the first visit and needs to be dealt with sensitively and with some trust being developed over time. Also, the way that the clinician and the patient or the client interacts can be different. So we talked about not stereotyping and not painting every immigrant or refugee family with the same brush. We need to be flexible and capable of reading the situation. I think we also need to keep in mind that in some cultures, seeing a physician is either not common, or it's for very specific reasons, or the physicians are seen as such authority figures that they actually lead the visit. It's much more paternalistic, and individuals may look to you to actually set the agenda for the visit. So we need to kind of incorporate that into our practice when we're dealing with these families. Getting a sense of immigration status will be important, although often that can lead to some semblance of not so much conflict, but at least mistrust. People in this situation sometimes will feel that by divulging health information it can affect their immigration status, which is not generally true, if ever. Certainly it is not necessarily the most important thing in terms of dealing with the family themselves. It obviously has something to do with in terms of how you are remunerated or how the hospital gets remunerated, but often that status, that health coverage status itself will tell you what the immigration status of the child is. And also just knowing the cultural background and the migration experience. We talked briefly that the journey for each family is very unique. Some of them will have had exposure to extremes of hunger and poverty and war and violence, and others less so. So keeping in mind that everybody brings different things to the table, and not that dissimilar to other families that you see on a regular basis, but sometimes unfortunately at the edges or the extremes. And in order to help with some of these things, including interpreter usage and understanding of the healthcare system, if you're on our website, what you would get is the ability to access information on all of these areas. So again, we encourage you to walk yourself through the web resource if you have a moment, and certainly these areas that have been very well developed by our editorial staff can be of huge help. Now, The history, you know, I feel somewhat ridiculous sitting up here telling clinicians how to take a history or how to do a physical examination, so please bear with me. It's not to be demeaning in any way. It's trying to just focus in on some of the areas that may be of particular difference or interest in this population. I mean, the chief concerns are the chief concerns, but sometimes the right question really is just, what can I do to help you today? What can I do to get things rolling? It may not have a medical indication whatsoever. It may be filling out a form. It may be helping address housing or settlement. So sometimes that's an easier way to proceed. Doing a head-to-toe review of systems has its place in medicine, but sometimes you find things that then you will need to deal with, so you have to prioritize over time what you're doing at that particular visit. And also getting a sense of sort of family history, not just sort of the family history and the diseases and the operations and potential genetic disorders or things that can affect the child, but even just, you know, what's the child's real full name? You know, where have they come from? What is their family dynamics in terms of who's kind of who's the parent and who's actually the primary caregiver? I mean, I'll use the example even of my own family. My grandfather in 1951, when he tried to emigrate to join his brother, Frank Salvo, who was living in Dogwood, Connecticut, got to Ellis Island. Ellis Island got turned away, sent to Pier 21 in Halifax, and when he got off the boat, his name became Di Salvo, not Salvo, because he said, I'm from the family of Salvo, which translated becomes Di Salvo. And it happened to the O'Duffys, my wife's great-great-grandparents, when they, under persecution, changed their name from O'Duffy to Black. So it's been happening forever, and unfortunately I think it will continue to happen, and it sometimes makes a difference as to how we view the family structure. As well, as I was saying, the family relationships themselves, you know, is the family united? Where is the rest of the family? Is this just a stopover? Are you in Edmonton today, but your ultimate goal is to get to British Columbia, where the rest of your family or your community is? All of these things have a role in helping you determine what to focus on in terms of your interaction with the family. Children's ages, even their date of birth is not necessarily their date of birth, and how their age is calculated is not necessarily straightforward. Culturally, it can be calculated differently, and sometimes they just don't know when the child was actually born, if the family member who is with you may not have that information. Now, that's important when you're thinking developmental assessments or charting on a growth chart. Very important to try to figure these things out if possible. And also the birthplace or the country of origin. So it does make a difference if you know where the climate they're coming from, and so what they're dealing with, or the setting, their home environment, or their access to food and water, what kind of insects in the country that they stayed in. Were they in a refugee camp, or were they actually visiting through another country, and how much time was spent in each location? These are all important pieces of information that can help contextualize their story for you, as well as focus you in terms of helping from a health and mental health perspective. Birth information, I think, speaks to itself, although sometimes it can be quite difficult to elude. Jaundice, sepsis, perinatal issues, etc. And consanguinity, although it's not terribly common in most sub-Saharan African cultures, in certain Asian and Middle Eastern cultures it's quite common. And in the context of developmental disorders or dysmorphisms or neurologic abnormalities, it is important information to try to get. Now, again, I could spend a half an hour on this page, just the dietary history and growth alone, but certainly just again to focus in on the concept that children coming from abroad, internationally adopted and refugee in particular, have high rates of nutritional deficiencies and micronutrient deficiencies. But it also gives you an opportunity to look at food security, looks at starvation-induced stunting and developmental delay related to neglect. Immunizations, obviously, usually important and difficult sometimes to corroborate. So if in doubt, you know, try to get documentation, and obviously, if still in question, utilizing your resources either through the NACI website or through your local medical health officer. And as well, there's actually a downloadable tool that will be available through the website that will help with catching up or updating children's immunizations in the face of inadequate documentation. So you can certainly download that. I think previous medical history and medical care speaks to itself, although just to focus a second on medical care, it's very variable in terms of what was accessed and how frequently, and depending on where the child and family have come from. And sometimes just that information alone will give you an idea of how much oversight or supervision there has been and how much intervention may have been undertaken. And medications, obviously, either prescribed, antimalarials, antibiotics, etc., but more commonly herbal or complementary or culturally specific remedies. Now, the psychosocial component, I can't spend enough time on this, unfortunately. In an initial visit, this is unlikely to be easily accessed or delved into in great detail, but I just want to highlight the fact that these children and families come with a wide variety of reasons for having immigrated in the first place. Their journeys are widely variable, and their previous experiences can be extremely different. On the flip side, their ability, their resilience, their supports in the community, their adjustment to the new settings can also be very different. So although we cannot paint everyone with the same brush, we do need to be alert to the mental health components of health and well-being, and the cultural expression as well as the cultural acceptance of mental health related issues. Our website hopefully provides an excellent opportunity and an excellent primer in that area, and I encourage you again to review this. Certainly PTSD and depression and attachment disorders, and in the next iteration adjustment disorders and many others are well covered there, as well as some resources in the nationally and provincially are provided. Now, how do you get to the bottom of some of these things? It's very difficult. Sometimes it is much to do with indirect questioning, everything from trying to get a sense of community life and home life to school, to attendance, to bullying and other issues of that sort. It's not necessarily going to be the HEADS questionnaire that we use for an adolescent in downtown Toronto, and it's not necessarily going to be the same line of questioning you might use for a well-to-do middle-class family in Ottawa. So it requires some finesse, and it requires some building of trust, and it gets done over time. The general assessment, physically, again, lots can be gleaned just by observation alone. You can get a sense of sick or not sick, acute or chronically unsick, dysmorphisms, development or cognitive kind of sense of where the child is, vital signs, obviously, to see whether there's tachycardia or dyspnea or things of that nature. And without going through every single organ system, just keeping a high level of suspicion for issues that are more common from the regions that these families are immigrating or coming from. So be they nutritional deficiencies or eye diseases or hearing deficits, certainly infectious diseases, as well as dental issues, which I think are under-recognized in general in pediatric practice, not just in assessments of immigrant and refugee children. And going through the list, the cardiovascular, the child with clubbing obviously has further evaluation. The child who has an undiagnosed cardiac murmur that's presenting to you for the first time, a child who might have hepatosplenomegaly, these are all evaluative findings that might pique you to look in either the infectious realm or the nutritional realm. The one highlight I will make is the genitourinary system, keeping in mind that, even in regular day-to-day practice, it requires significant sensitivity, but certainly in children and youth new to Canada, whose experiences may be very different and whose cultural values may be very different, this needs to be done in such a way that it's respectful and inclusive of the family, and sometimes has to be done in stages over time in order to actually get information that is useful as the primary care provider. Looking for female genital cutting, keeping in mind that pregnancy is always a possibility in females. Times of early sexual activity in males needs to be kept in mind. Skin findings as well, both from an infectious perspective and lesions, but also cultural, cupping, coining, scarification, things that need to be kept in mind and looked at that sometimes can get confused for abuse. And screening investigations, I won't spend a lot of time because unfortunately the evidence is not totally clear on this, but certainly there's some sense that targeted screening is useful, particularly what we see here, looking for anemia, looking for hemoglobinopathies, looking for iron deficiency and liver function and renal function, G6PD assay if they're in the right geographic location, and then infectious issues to some degree that Chuck will discuss. I will leave those for him. And then finally, just the concept of the future visits. This is probably the most important slide overall, frankly, in that, really, to do this properly, we probably need 2 or 3 visits at the very least within a month, sooner rather than later, so that you can complete some of this information. It helps with everything from completion of immunization status, making sure that treatments are adhered to, assessing, building trust, and being able to then look at behavioral difficulties or psycho-emotional issues or family stressors, as well as allowing you opportunities for anticipatory guidance. Again, everything from what clothing should we be suggesting that the child is wearing to safety belt usage and beyond. It also allows you the opportunities to then start to advocate on behalf of the families, provide referrals or resources, be it dentistry, optometry, local support services, settlement workers, whatever it may be, and then get a sense of the long-term stressors in the household, finances, food security, etc. The goal here is, again, not to be complete in a first visit. This is a 4-hour evaluation to be done properly, and that's why it takes time and trust building. But the main core feature is that it does take a different lens to care for these children properly, and hopefully through the website you can get some of that information. And I'm just going to walk you through sort of a 2 seconds of the website itself. How to get this information. For example, you go to the assessment and screening, you scroll down and you would go to medical assessment. And then for medical assessment you might say, well, geez, I'm quite interested, I've read about this, but now I want to look about cultural competence. I want to better myself in this region, and you move along. And then you learn that, geez, in terms of culture, usually we only see the tip of the iceberg, and there's more that can be looked at. And so you further digress and link within the web resource itself to looking at adaptation and acculturation. And this is just an example, obviously. I think, as I said, if you get an opportunity to play with the website a bit, I think you'll find that it's extraordinarily useful.
So coming back to Yemen, we had this issue about is this potentially HIV, and then the issue about the international medical examination or some testing before on the mother or on the child. Did they get it? So I think it's worth actually stating what actually happens in the international medical examination, because I think a lot of people have this perception that some of this testing is done for the child, and that that the children have or the parents or the family have this information. This is actually a requirement, a law requirement for permanent residents coming to Canada, but it only assesses, and I quote here, danger to public health, danger to public safety, and excessive demand on health or social services. So this is the reason for this medical examination, and it is not focused on the health of the child. Although there is some cursory developmental screen done on the child, take for example, or a cursory examination, it is not to help make a diagnosis or better the health of the child. There's on top of that, there's mandatory testing, but actually that mandatory testing comes with specific caveats. And specifically, they don't do a urinalysis in children younger than 5 years of age. So it has to be, the child has to be older than 5. They only do a chest x-ray in children who are 11 years of age or older, and they only do HIV testing in children who are 15 years of age or older. So although sometimes you would see this in your other patients, perhaps older children or family members, it's not routinely done. So in terms of HIV, not only are there routine ways that new kids to Canada can actually acquire or have transmission associated with HIV in terms of mother to child transmission, much the same as what happens in Canada, but there's other things that don't occur as much in Canada. Specifically, mother-to-child transmission, you have certainly perinatal, which is one of the more common ones in Canada, and then breastfeeding, which is culturally important around the world, and there's a taboo associated with non-breastfeeding. So there's a stigma and there's a concern associated with the diagnosis with HIV, and that some people new to Canada will not stop breastfeeding if they know they have HIV because of this issue, because they'll be outed, so to speak, associated with their diagnosis. Pre-mastication of food, sexual contact, whether that be consensual or through sexual assault. And then in many areas of the world, there's healthcare associated infections, blood transfusions, but certainly even routine immunizations at times, they reuse needles and syringes. And then there's traditional practices such as circumcision and scarification that can lead to transmission associated with HIV. So who should you test? So certainly if the parents tested positive for HIV, and the parents will be tested for HIV in terms of permanent residence, certainly because they're older than 15 years of age. If the birth mother was deceased or due to a known or unknown AIDS-related illness, the birth mother who is not in Canada and the child is from a region of or a country where there's more than 1% HIV prevalence, the child or adolescent has a risk factor associated with transmission, or the adolescent is from a region of or country with more than 1% HIV prevalence, or is found to be pregnant. Or if the child or adolescent, if anybody has clinical manifestations associated consistent with HIV. So you say, okay, so 1%, we talked about 1% here. Where are we going to find that information? Well, you can go to our website. And you go under medical conditions and HIV AIDS, and then you can go down, and we actually have multiple different resources for you to look at this. And specifically, you can see on the right-hand side, Table 1 has HIV prevalence globally by region based on 2010 data. Now, this is by region, and you can see East Asia and Southeast Asia has 0.3% and 0.1%, and that would not reach the threshold of 1%. But it's more important actually to probably go to this country-specific data, and we have a link in there so that you can go to the UNAIDS country-specific data to look at the HIV prevalence, take for example in Myanmar, take for example in Cambodia, which potentially would reach the threshold of 1%. So these region issues, again, talking about homogeneity, it's not the rule. It's actually the minority of situations. So clinical manifestations of HIV, we're not meant it's not meant as a primer for HIV. There's many textbooks, many review articles associated with it, but just to have an index of suspicion because it can present in very non-specific ways, such as neurodevelopmental delay, diarrhea, lymphadenopathy, and thrush. Then what's probably most important with regards to HIV and specifically for newcomers is talking about testing. And so it's crucial to have a professionally trained, culturally sensitive interpreter in the room. You do not want to get into the situation where you utilize the child as an interpreter, because not only are you putting that child in a harmful and in a bad space that can lead to harm, but it can lead to a lot of medical errors associated with the discussion. So it's important to have a professionally trained interpreter and to ensure that that is there before you talk about pre-test counseling for HIV. It's important to clarify the confidential nature of your discussion. However, you also need to tell them that HIV is a reportable disease, and because there is mistrust associated with the government. And explain to them that HIV is not a specific reason for people's claims of refugee status or immigration status to not be accepted. And it's important to explain to the parents specifically that a positive test in a child typically can lead to a diagnosis of HIV in his or her birth mother. So you're actually kind of testing two people at the same time. You need to describe the tests and the risks and the window periods and the sensitivity and specificity and those kinds of things, but certainly in non-medical jargon. Take a history about what potential risk factors are with HIV, and then talk about what HIV means. So maybe in that country that they came from, HIV is a death sentence, which is not at all the situation in Canada. We have combination antiretroviral therapy that has made HIV into a chronic disease now. And then it's important to schedule post-test counseling. What about tuberculosis? So we know tuberculosis affects a lot of us in the world and predominantly affects people outside of North America and outside of Canada. You see the darker regions have the increased incidence of tuberculosis based on this WHO map. And we also know that up to about 1/3 of the people in the world are actually infected with tuberculosis. And it's really a disease associated with the social determinants of health. And it strikes people down in the primes of their life, unfortunately. It's estimated that almost 2 million people die every year of TB, and that HIV has magnified the disease associated with tuberculosis, specifically because it attacks the immune system that is important to keep tuberculosis under control, and that you significantly increase the chance from going from infection to disease, almost 10% per year, and every 3 minutes a person with HIV dies of TB. Where in Canada, we're seeing this exact phenomenon. It reflects the world, right? So we're seeing foreign-born people as the ones who have tuberculosis. 80% of people come from high TB endemic countries, and people who are new to Canada have a significantly increased risk of going from infection to disease within the first 5 years of arrival, almost 50%. So you have to have that index of suspicion, and they're more likely to have resistant tuberculosis. This study, I'll just make you aware of, again, underscores the importance of culturally competent professional interpreters. So this is done in Toronto by Michael Gardam's group, looking at 1-year survival for foreign-born active tuberculosis based on patient-provider language coordinates. So if you're concordant in terms of communication, so your patient can speak English, and you can speak English, and you speak English to them in terms of their TB active disease, they did relatively well, which is the red dotted line up the top. If you're concordant in another language, take for example Punjabi, but both the healthcare provider and the patient spoke it, then they did well, relatively well, not as well as if you're able to speak English. But if you're unable to communicate to your patient, then you had a significantly decreased risk of survival at 1 year associated with active tuberculosis. Again, underscoring this huge need to have interpretive services. This is a primer on TB, but basically what we're trying to say is that the vast majority of people, when you're talking about screening for TB for children and youth new to Canada, you're talking about screening for infection. You're not screening for disease. Disease is somebody who's unwell, typically, and you want to do screening by infection. Who do you screen? This is listed on our website, and I won't go belabor it, but essentially, basically, you should screen people who are at higher risk, and there's higher risk criteria associated with it. And you screen people by doing a TB skin test. The last slide I have on tuberculosis and infectious diseases is interpretation of the tuberculin skin test, which is important to know that you need to know your induration, and you should write down what the induration is rather than positive and negative. If you say positive and negative, it really depends on the underlying risk associated with that patient. So take, for example, if the patient had 8 millimeters of induration, but didn't have HIV infection, close contact with somebody, a contagious case, then they would be considered negative. But if you subsequently tested them and they had HIV infection, then that's actually now a positive TB skin test result.
Okay, guys, so we're almost finished, so thank you for your attention to date. And I apologize in advance for those of you who were at the North American Refugee Health Conference a couple of weeks ago. This is a recap, essentially, of that. I did want to, however, touch upon, and Chuck and I thought it was important to touch upon the concept of how we've gotten CKNC to this point in time, and then the sort of the project itself. So, you know, a little bit about CKNC. We've been through that already. But what I wanted to do is about how we've gone through it. Obviously, the objective of the actual project itself, I think, preaching here to the choir, is the improvement of health equity and outcomes for children and youth new to Canada. And the goal is to do it by providing individual care providers with a free, evidence-based, bilingual, easily accessible, and peer-reviewed website that provides information and tools to actually allow you to do that job every day. In terms of how we've proceeded, you know, the project has occurred over many stages and with countless hours of work. Certainly the unique aspects of it include the iterative components, the fact that there has been both external sought out external needs assessments, as well as looking to experts in the field to provide their opinions before we proceeded to content development, as well sort of the dissemination and outreach that's ongoing as we speak, and the continued feedback and review from audience and users, which then seems to push us forward to the next level and the next layer. And just to give you an idea of time, this is, you know, the needs assessment alone was a 6-month period. The funding search, also known as the begging for dollars component, was 18 months in the making. And from the point of having a very first sort of open component to the infrastructure that supported us all to the time of first publication was actually only 18 months, which seems like a long time, but it's actually not that long for the amount of information that was put up on the web. In terms of how we've gone about it, again, I think the interesting components are the fact that it is quite iterative. You know, we've looked and received information from multiple sources. There was a whole host of planning and thinking and prioritization that went into it. The actual research, synthesis, drafting, redrafting, assessing, reviewing took many, many months, and then ultimately both publication as well as dissemination. And then we seem to start the cycle over again. Although we don't have endless amount of time or money on our hands, we still have another 9 months of generation of information and content and solidification, and hopefully also we will be able to continue to provide support to the project moving forward, and sustainability is a key component of our next 9 months of thinking. The collaboration was huge. We had a gross of people involved, 144. And I'm not going to go through all the different areas and things that were done, but suffice to say that the enthusiasm for the project, I think, speaks to the need for the content and the need for the information. People were jumped on board when we actually approached them, and we had many, many layers of involvement. And in terms of the dissemination, apart from the actual web resource itself, which is obviously self-explanatory to some degree, is really multifaceted and strategic in nature. And this is just one of the fora that we're looking at. Overall, we have, I think, 9 opportunities of presentation over 7 different conferences. We have information that is being slowly leaked out on listservs and Twitter accounts. We are targeting, specifically targeting about 250 organizations and or groups that are clear and obvious people who need to have the information disseminated to them. We think that this certainly will lead to a multi-pronged attack that will make the dissemination of the information more useful. At the end of the day, it's not about the web resource, it's about the translation component. We won't be able to necessarily measure that immediately, certainly not on April the 1st of 2014, which is the day after the project closes, but over the next 5 to 10 years, the hope will be that we'll be able to measure some outcomes and changes in practice. Now, what went well? Volunteerism was hugely successful. 88% of the individuals that we approached for peer review helped us out. And in fact, they were often the individuals who contacted other individuals on our behalf or provided additional information. We started with the hope of getting 12 panel reviewers to review the actual website with cases and filling out surveys, and in the end we actually had 53 or 51, I believe, and they were split between family doctors, pediatricians, and allied health professionals equally. Editorial collaboration was hugely important, and I think was very, very successful. One of the things that most of the editorial staff listed as important to them was the fact that they'd made contacts across the country with like-minded individuals and learned along the way. So we'd like to continue to support them in their work. The staff support in communications was remarkably successful. You know, we were fortunate in that we had funding for a full-time project coordinator, Barozzino, as well as extensive support from the CPS communications team, and some of whom are with us today. Without them, we would not have been able to sustain the duration and the intensity of this project. And we've also had communication now spreading out from here. As well, the content component, we developed over 33 topics in 18 months, more than twice what we actually expected to. So that was successful. And true to our pediatric roots, the budget, we were always on budget, so pediatricians are great at doing more with less. I'm not sure what it is about us, we're a very frugal group, and that's great. So we came in on budget both years, and we had, fortunately, very flexible support from the CIC that allowed us to move budget around as fires arose. And then ultimately, the audience feedback is very appropriate. So we've had, you know, in terms of relevance and readability and comprehensiveness and credibility, and then, you know, will people come back in the future and how do they overall rate it? We've had very, very strong ratings. Now we are not deluded by this. We know that most of the people who are providing these currently are individuals who have helped with the review and have an interest probably in this area, but hopefully this will carry on, and the dissemination to individuals in the field will provide the same feedback. Now there were many challenges, not the least of which were the fact that it's a non-traditional project, so some people had lots of writing expertise and others very little. We used writers, which some individuals found useful and others found very difficult, but it helped to kind of flatten out the stylistic differences. And also just the concept of writing for the web. You know, it's a different animal, writing for the web. It's not, it has an iterative component to it. It doesn't get published all in one fair swoop. And it also isn't necessarily valued at an academic level as traditional peer-reviewed papers are. And also the evidence-based approach. There was a variety of content with a variety of support, and our main goal was to try to be as transparent and credible and useful as possible, and that took a lot of work to do. So it was not an easy thing. So I want to again thank everybody who was involved with that, because just trying to keep people organized and enthusiastic for several years is hard to do. And I think the lessons learned are kind of buried in there. I would like to leave some time for questions, so I'm just going to give it some closing remarks from Chuck, and we'll go from there, and then we'll open it up to some questions.
So over this time period, hopefully you've had an interesting amuse-bouche, as Tony was saying, a quick primer and introduction to the web resource. We've certainly talked about and shown you that there's significant heterogeneity associated with children and youth new to Canada, and that there's a lot of complex issues associated with them, and a lot of challenges, and we've hopefully given you resources to be able to tap into to deal with many of them. We talked about the medical assessment, and we talked about infectious disease specifically, but there's many, many more topics and many more to come, as Tony was saying, in the next 9 months. And then we talked about what was great, and again, we can't thank everybody who was involved in the project any further because it was a huge collaborative and interesting project that not only Tony and I, but hopefully everybody who was involved in the process was interested in and also learned lots. So again, I'd like to thank the editorial board, who most of our, in this picture that we took at our meeting a few days ago, and thank you for coming, and please tell us what you think about the website. Thank you.